Item in the agenda is membership and terms of reference. I just want you to make note of that terms of reference. And we also have a policy now, new policy of introducing ourselves before we start the meeting so that we all get to know each other as the time passes. So can you please, when your turn comes, can you please introduce yourself? I am Councillor Paul Egil-Shelvan. I chair this Health and Wellbeing Board meeting. Thank you.
Hello, I'm Graham Sayers. I'm GP Nanik, clinical lead at the north locality of our ICB.
Morning everyone, I'm Jill O'Neill. I'm Executive Director for Public Health, Communities and Inequalities based in the Council.
Hi there, Vicky McFarlane-Reid, Director for Business and Development and Enterprise, Newcastle Hospitals.
I'll go this way. Oh, that's gone red. Hi, I'm Rachel Richardson. I am Director of Place at Northumberland, working for the ICB.
Hi, I'm Robert Taggart, and I am an Information Analyst at Northumbria Healthcare.
Hi, I'm Jill Harland, a Consultant in Public Health at Northumbria Healthcare Trust.
Good morning, David Thompson, Chair of Health Watch Northumberland.
Good morning, Debbie Nugent, Health Watch Northumberland.
Good morning, colleagues. Graham Writer, Director for Children's Social Care, Young People and Families in the Council.
Morning everyone, I'm Graham Binning, I'm the Deputy Chief Fire Officer at Northumberland Fire and Rescue Service.
Hi everyone, Neil Bradley, I'm the Executive Director for Adults at the Council.
Liz Simpson, County Councillor for Newbiggin.
Wendy Patterson, County Councillor for Long Houghton and Portfolio Holder for Adult Social Care.
Morning everybody, I'm Ashley Eyston, I'm the General Manager for Gateshead and Northumberland North 19 Services, Harrogate and District Foundation Trust.
Hello, Rob Murphin, Director of Planning and Housing at the County Council.
I'm Liz Robinson, Senior Public Health Manager here at the Council.
And I'm Kevin Higgins, the Employability and Inclusion Manager in Economy and Regeneration.
I'm Leslie Bennett from Democratic Services, Northumberland County Council.
Absence.
Apologies from Sherry McCartney, Hilary Snowden and Councillors Renner Thompson, Watson and Ferguson.
Thank you. Minutes of the last meeting, can I sign it off as a true record of the last meeting? Thank you. Disclosures of interest. None, I think. Now, there are a few changes in the agenda item. Number 5 will go to the last one. And also item number 6, Mr. Buckley couldn't make it. So that needs to be cancelled. Therefore, that brings us to item number 7, to receive a presentation and summary from Alistair Blair. Thank you. Alistair, yours. Yeah.
Hi everyone, just really to give an update on the kind of community promise. By community, this is seen as the community of our staff, on the understanding that our staff live and work in the environments of Northumberland and North Tyneside. And this is going, hopefully, as you'll see, beyond just employment to looking at their well-being and actually the implications for their family and, as a result, the wider community that they all live in. I think we're the first NHS trust in the country to look at a community promise, and it's based on 6 key themes, which I'll outline. It's gathered quite a lot of traction locally and nationally, which is good. And I think this is something around getting that momentum about realising that a lot of our staff are actually on very low salaries. A lot of public sector are. What are the implications for them? How can we support them? What are the bits that we can do to help them? Because it's not just them, actually it's their direct family. Some of them may be the only breadwinner within their family. And actually we've started looking at, and I suspect this will come up later, at, for example, the socioeconomic deprivation within our own employed staff. We always think about deprivation as being over there, but actually some of our staff live in some of the most deprived communities in Northumberland and North Tyneside, and it's important that you don't just talk about it being outside, it is actually within as well. So we looked at this in terms of what's within our remit of control around poverty, within our staff, around how we promote education, around apprenticeships and so forth. What can we do as a major employer? And I think we are all aware, and I think colleagues in the council are very aware of the fact that the public sector is one of the biggest employers in Northumberland and North Tyneside. What do we can do about creating jobs? Things like the factory site, the manufacturing sites that are not directly health related, but we do, are actually quite significant employers, and the same with what we do with NHS Fleet. What can we do about improving the environment that we live in, and pay particularly around staff well-being? So it's predicated on these 6 points. It has got quite a lot of national awards, which has been great, and that publicity just helps kind of publicise it amongst our own staff. But I think what you're less interested in is awards and what it does. So what are the inequalities that we're looking at within the Equalities Board? What are the unmet needs, both within our staff and the patients and things? And I think this overlaps with where colleagues are going to talk in a minute. But this is some of the specifics that I think you'll be more interested. So we actually now have financial well-being clinics. We've had, particularly during the winter, we had 42 days of free main meals. And for some of our staff, that was the hot meal that they got of the day. We have created our own community bank for financial reasons, and you know, the fact that of our 12,000 staff we've got just under 10% using that community bank to put their savings in a safe and effective way, it is really impressive. We've worked with things like Alnwick Garden to get free places for staff to take their own families to for breaks, discounted travel passes for staff, and also fresh food boxes. We've also looked at, for example, if we've got now a mobile fruit and veg stall that comes out to make sure that, you know, staff are able to get fruit and veg across all of our sites. And, you know, there's also been bits where we've done, for example, mini scrubs, which is, they're just theatre scrubs. We're going into schools and actually telling them not that they're all going to become surgeons, but there are loads of different ways that young children can actually then go on and get careers within the NHS across the spectrum, be it from porters through apprenticeships, through nurses, etc. And I think getting that parameter around it's not just the standard jobs has been really powerful within that. And the mini scrub project within the schools, as you'll see, has been really, really popular. It just gives them, they dress up in them, they get an idea of it, but they then get the message that it isn't just about doctors and nurses, it's much wider than that. Looking at the Good to Go app and quite a lot of other bits. And I think some of the successes we've had is an increased level of apprenticeships coming from our deprived community, an increased level of apprenticeships coming from those with disability. We're really looking at that widening participation in lots of things, trying to link things to social value, what we do with surplus food from our own canteens, etc. And also then work with the Department of Levelling Up. How can we influence, for example, policies around fit notes to try and make it easier for people to get back into work where it's the right thing for them. A couple of quick figures. You can see that since we started this is not about showing statistically significant numbers, but you can see there's a definite trend with an increase in people from both other ethnic minorities and also disability, which is really positive. And I think getting people into apprenticeships who may necessarily not have the standard academic route's been really powerful. When we've got the new nursing academy in Cromlington, which will open next year, that's specifically aimed at people who may have done apprenticeships, may not have done the standard route into nursing, but will then go into nursing careers. So it's not about 18-year-olds coming and doing it as an alternative. It's often about people who've got wider life experience looking at their career. Quite a lot around some of the evidence, looking at how this can create a bit within the wider public sector, because I think, as well as being good employers, I think this takes it wider and has a ripple effect into the communities that we all work in. I suppose one of the reasons we've publicised this is to try and get that as a bit of a momentum going in other parts of the NHS, and it's great to be able to come and present it today. And I think the last thing is, where are the opportunities to work with, particularly other trusts and also through the county council? What can we do around, for example, homelessness? That there are people without stable accommodation even amongst their own staff, and what we all talk about is homelessness, but people without stable accommodation are the most vulnerable at becoming homeless. So what can we do in a joined up approach for that? How do we link with, DWP? How do we link with schools to make sure that our young people do have careers that are meaningful and productive for them? We've tried around ex-offenders to see what might be available. It's quite difficult because, as you can imagine, we have to be really strict around safeguarding and governance with regards to our employees, but there may be areas such as potential laundry developments, manufacturing and other bits that are not around direct patient care, where actually their safeguarding issues wouldn't present a barrier to them. But, so we've got to use the appropriate lens for that, and what can we do about the wider inequalities. So that's really just to give you a flavour of what's going on. But I think it has gained a lot of traction, and I think this idea that your staff may have needs, that your staff are part of the community, and actually supporting them actually hopefully nudges the whole of the communities in which we work. That was it.
Thank you very much, Alistair. Very impressive presentation. I think it would be nice to see how the potential, the vision for potential joint works will develop. So I think that would be interesting.
If we look at the collective bodies represented in this room between fire, police, other NHS organisations and county council, we're probably by far the most significant employer across the whole of the county, and I think looking at that with traction, I think could be really powerful. And these are not all expensive measures. That the community bank isn't expensive, takes some admin, but it's been immensely powerful. Avoid staff going to loan charts, paying ridiculous interest rates, and has been really excellent, for a number of staff. And there's a lot of other interventions that aren't expensive.
Are there any questions for Alistair? Yes.
Yeah, thank you, Chair. I mean, Alistair, that was really, really interesting and really positive what Northumbria is clearly doing for its staff group there and trying to expand that out. I mean, my comment was going to be on the community banks bit, and you mentioned as well financial wellbeing clinics. I know the council does as well promote community bank within Northumberland, and I suspect there's probably strength in join up around that, because we do know those banks are more sustainable with the greater number of members that they have. So I guess I'm speaking as the council here, because I don't directly deal with community banks on the council's behalf, but I suppose we'd be really interested in a dialogue about join up on both those things. We're engaged with Citizens Advice Bureau as well around financial advice and well-being, and probably early on in the development of these projects, a bit of dialogue across organisation. Northumbria might be able to jump onto things that the council are doing and vice versa. We'd be really interested in piggybacking on what you're doing there, which sounds fascinating, some of it. So.
Let's link outside, but I think that the point about this is there's an offer about collaborative working and how we can achieve it. So, yeah, absolutely.
Yes,
Yeah, just coincidentally, there's an ICB People's Committee meeting today, which I've not been able to go to. But I think, that is about the join-ups. But I think there's more opportunities, quicker opportunities to be able to do that locally, actually, rather than waiting for the bigger picture. So as with Neil, I think opportunities for us to share learning. I mean, obviously the work with schools will be one of interest for social care and children's social care about that. So a number of ways we could do that, I think.
It's about the right scale. I think for some of our staff, if they started a North East community bank, might just fit. They actually quite like the fact that it feels local, and that we're working with local partners. There will be other things that I think should be done at scale, and I think it's getting the right scale that works for the population.
Chair. Alistair, that should be applauded. I thought that was excellent. What the Trust is doing is really wonderful. And just to echo Neil, I've got it on. Just to echo Neil, I think it's a real incentive for Northumberland County Council and yourselves to work really closely together, much more even than we're doing now, especially in regard to the community bank, which is one of my passions that they're so important to have. So thank you so much.
Yes, please. Thanks, Alistair. This feels like an invest to save to me, in that obviously looking after your workforce, but it's also looking after the community. But I assume it is done at some expense to Northumbria. So somewhere in there must be some thoughts about how the economies of it work out as well. Because if you were looking to other partners, they'd be thinking, well, yeah, that looks like such a good idea, but in the days when we're currently looking at restricted budgets, how do you make the case for your invest to save? So I don't know if you've got any comments on that.
It's a good question. I suspect everything's difficult in financially strict times, but some of this is about the psychological symbolism. So a warm meal during winter when there was a lot of doom and gloom about fuel crisis, etc. It was probably about £3 maximum per head of staff. If you look at the wage bill, that isn't a lot, and that was for 45 days. The psychological well-being, and I suspect if we didn't relate this to staff absence, etc., but I think if you look at our staff absence, it is low. So you've got an economic argument there, because actually you don't need very many members of staff to be off for 1 or 2 days where it blows the £3 for the lunch out the water. So in terms of, I think a lot of this is the psychological rather than the actual. It's not about giving people £3. That's immaterial. It's about saying you're looked after and people are thinking about you, and then their psychological response to that. And I think that's really important. So I think most of this is actually relatively small amounts of money, but the impact I think is wider than. But you're right, £3 out of a budget is, it creates a bit of a hole. But I think you then need to be clever about actually the ways that you account for that. And if you can prove, if you needed to in a business case, that you've got a decreased staff sickness, increased staff satisfaction surveys, all of those things are tangible outputs.
Any other questions? Jill, please.
Thanks, Alistair. That was really helpful, and it's always important for us to step up when we hear good practice, I think, and look at our own house and see what we can get in order. And I think that's part of us having this board, isn't it, to share that. But building on it, as we all know, we've got the Inequalities Roundtable on the 13th of July instead of this board, and the key strapline is people, policy and place, and this is the policy aspect of it. So all of us are part of large employers, and I look at the VCSE sector in its entirety is a large employer actually for us as well. Then the second part of that day is absolutely going to be look at what is it that we can do at scale and learn and share from each other, and the gives and the gets from doing that. So that's a really good prelude into that deeper conversation in July.
I completely agree. And I think just to re-emphasize, I think we all, and Jill might want to comment on this in her presentation, but when we looked at the distribution of income and where our own staff were living in some of the most deprived areas, it stops it being about deprivation out there. It's all within, and actually it's cross-cutting, as I think council members will know too well.
Thank you. Thank you. So we move on to the next item, health inequalities. A presentation from Jill Harland and Robert Taggart, please.
Good morning. My name is Jill Harland joined, I'm a consultant in public health and I work at Northumbria Healthcare Trust, and I'm joined by my colleague Robert Taggart. Do you want to introduce yourself, Robert?
I'm Robert Taggart and I am an information analyst.
Robert, can you press the mic so that people can hear?
Is it the left hand button, the right hand button?
There
we go. Yeah, I'll just say that again. I'm Robert Taggart, data analyst working in public health with Northumbria Healthcare.
Okay, so this morning we're going to give an update and an overview of, I guess, our Health Inequalities programme. I'm going to talk a little bit about the infrastructure that supports our work around health inequalities. But I guess just to start, I think it's important to recognise that probably about 80% of health inequalities and the kind of influence we have around them is outside of the NHS. It's about the wider determinants of health, and so it's important to recognise that. But the NHS still has a really key role in health inequalities, and that's mandated in things like the Health and Care Act of 2012, the NHS Long-Term Plan and the Core 20+5. So it's important to think about that, and I think one of the things that I take away from that kind of 80%, 20% is that it's the need for the NHS to work collaboratively, and it's the need for us to think about how we look outwards and look to the community in terms of how we think about health inequalities. So COVID, I guess, put a really stark spotlight on health inequalities, and health inequalities and discussions around them, the evidence around them has been of concern for many, many years. But I think for COVID, it really focused the NHS's attention on what that meant. So in our trust, we now have a Health Inequalities Programme Board, which is a strategic board that helps us to have that oversight in terms of what are we doing as an organisation around health inequalities. And you'll see on this slide that there's some objectives there. And to start with, one of the really important objectives is how do we understand health inequalities from a healthcare perspective, and how do we quantify them. So a lot of the focus on the Health Inequalities Board is on embedding our understanding of health inequalities into the routine reporting of the organisation, which is a journey. So it wasn't necessarily there. So unless we're counting the health inequalities, we can't see them and we can't act upon them. So a lot of work around us understanding them better and for them to be routine. Another objective of the Health Inequalities Board is about bringing together all of the work under one umbrella so that we can really understand how are we being efficient and effective in our work. So the board helps us to raise the profile of health inequalities in the organisation. It brings partners together. We have members from the local authority on the board, from the voluntary and community sector, from academic institutes. So it's that kind of collective lens on this really important programme of work. Very much the focus of the board is about what we can do directly as an organisation, so what's in our gift to change, but also what can we do as a good partner with other organisations around the health inequalities. The board meets monthly, so we have an hour every month where we come together, and in that hour we tend to bring different priorities to the board. And we ask clinical colleagues or colleagues that are presenting usually 3 questions. So what do we know about the issue that you're coming with? What do we understand about the inequalities? Where are they? What can we do to improve them? What resources are needed? And what do you need from the board to help you to make those changes? So the board, as I said, was established about 2 years ago, and I'm going to talk about the initial priorities that came to board, and these are the things that we started to work on, but subsequently we've got new things, but I'm going to focus on these initial ones because this is where we've really got some evidence now that we are making a difference. And very much the focus of our board isn't on discussing health inequalities, it's about the action that we need to take collectively to address them. So here one of our projects was looking at health while waiting, and you'll all be familiar with the kind of concerns. It's in the news an awful lot about people on waiting lists and the concerns around the inequalities around that. So this work started with us looking at our waiting lists to see if there were inequalities in waiting times. And we were quite reassured that actually there wasn't a difference in waiting for people in the least deprived area and the most deprived areas. But what we did find was that there were inequalities in people's quality of life while they were waiting. So if you had tobacco dependency, if you had experiences of overweight or obesity, your self-reported life experience wasn't as good. So this was a real, I guess, lever for us to look at what are we doing as a trust while people are waiting. And I guess this is in the context of other work that's happening regionally as well around waiting lists. So at the moment, we're piloting some work with our orthopaedic colleagues and our gastro colleagues to look at a health coach model within waiting times. So this is about looking at a health coach offer to patients while they're waiting to think about what matters to them, how can we address some of the risk factors around a better outcome from surgery while you're waiting. And this comes to the board will hear what our plans are, they'll provide that oversight of that. So this is kind of in progress, and we're evaluating it to look at the outcome measures. So one of an example of something that the board's concerned around. Alistair's very eloquently talked about our staff being part of our population and there being inequalities within our staff in terms of health and well-being. So what we've done as a board is we've looked at actually, do we know what those health inequalities are across our staff population, and we've undertaken a health needs assessment. So last year we did this piece of work which involved synthesising lots of information and evidence about what we know about our staff. So things like the NHS staff survey, we do a local survey every quarter. We have ESR data, we have occupational health data. So we were able to synthesise all that into an interactive dashboard. We piloted it using PowerPoint, but this year we're going to put the visualisation into Power BI, and the intention is that we'll be able to share that story about our staff across business units. And it's really powerful because we can see that across lots of different risk factors we have this variation, and we can think about our staff health and wellbeing offer in a much more targeted way. So it's a journey, but it's very much kind of communicating to the organisation and the people who have influence around change, things different, and things might be different but not acceptable, and what can we do about it. So we've done some deep dives as part of this process, and we've looked at musculoskeletal health, and we've looked at financial well-being of staff, and again we've seen that variation. So our staff in bands 1 to 3 are much less likely to access our health and wellbeing offer. They're not necessarily aware of it. So we found that there was examples of digital exclusion within staff groups. So all of this is really powerful evidence, because then we can think about the quality improvement that needs to be attached to that evidence. So really positive and very much interdependent in the organisation. So the question around resources, actually a lot of our interventions, we've got the assets within the organisation, and it's just about applying them much more in a focused way once we know about the inequalities and how do we do something about them. Hopefully some of you will have heard about the work that the Trust has been doing with the local health index, because you've also been involved in this being developed. So the Trust worked with public health colleagues within Northumberland and North Tyneside and the Office of National Statistics to draw upon a national local health index but to use local data so that we could have a more granular understanding of place. And we've now got this experimental local health index that helps us look at 3 domains, so healthy people, healthy lives and healthy places. And we can see across that smaller area how we compare to the England average. So we've now got this index that we've got in an experimental version, and the next stage is that we want to look at how we utilise that and how we make it non-experimental. So there's a proposal gone to NHS England with the ONS, and that's sitting with them now, and we're very much hopeful that this will be able to be opened out so that we can use it at an ICS level and beyond. So really positive. And again, this helps us to better understand the situation in our local communities so that we can look at differences, we can look at assets, and then it helps us to be really much more targeted into the planning, etc., that we do around health inequalities. Another example that we're working again with Northumberland colleagues on is a lung cancer case finding pilot. So this is targeting those with chronic obstructive pulmonary disease who are over 55 and are living in the most deprived areas who are at risk of developing lung cancer. This pilot was successfully started in North Tyneside and the results were really positive, where we were able to detect our detection rate was higher than average, so we've been able to roll this out to Northumberland with some funding from the council, and we're currently piloting it with Valen's primary care network with a view that it links in with the targeted lung cancer health checks once they come on board. So again, an example of kind of looking at our population, looking at where there's more risk and targeting that intervention. The long-term plan, very much within the long-term plan was that recognition around tobacco dependency and that being a real concern around health inequalities. So the Trust has had funding to implement a much more robust offer to patients who are tobacco dependent. So this has been operationalised in the last 12 months, but all of our smokers now that are coming into the Trust should be receiving nicotine replacement therapy within 2 hours of admission. They're offered intensive support while they're an inpatient, and then that connection out to the community when they're discharged, so that we've got that pathway around supporting people who are tobacco dependent. Linked to tobacco dependency, this is our Best Start in Life service, which is another service that was supported through long-term plan funding. And this again is around supporting women who are tobacco dependent in pregnancy and following them right through their pregnancy, so that we can really understand some of the barriers to them quitting smoking and what are the enablers. So this again has been operational for about 12 months. And we're already seeing that the rates come down around that. So it feels like the model is working. We've, as part of the model, there's an incentive scheme that's been funded by the integrated care system. So at different points within the relationship with the mum, if they're still not smoking, they get an incentive of a Love to Shop voucher, and it feels like it's really working. And really some of those women that really struggle and there's lots of barriers to them quitting, the incentive scheme seems to be a real route in. So we're really positive about those initial figures, and we're evaluating this service to make sure that we are continuing to make that difference. Alistair's talked about the community promise, and as passionate as Alistair is, you know, it's about that kind of what can we do as an organisation, as an employer, and our decision making around procurement, around employment, how does that make a difference and benefit people's health and well-being. So a really important programme that feeds into the work of the Health Inequality Programme Board, and again enables that joint discussion around where we're going with it, what do we need to do, what are the opportunities, how can we do more. The colposcopy work was a piece of work. We looked at our non-attendance rate for outpatient appointments across the Trust, and within our non-attendance the rates were higher within gynaecology, and within gynaecology the rates were higher within colposcopy. We started with the data, so we looked at who was not attending and who was attending, and we saw that there was a relationship with deprivation. So women who were living in more deprived areas were less likely to come for their appointments, and younger women were less likely to come for their appointments. So as part of that data understanding, we then needed to look at the qualitative insights. So we did some work under the auspices of an audit to reach out to people that were attending and not attending to find out some of the reasons why they weren't coming into the hospital to access their appointments. We also spoke to staff to get their perceptions. What we found was that there was a mixed picture, so there were themes around transport, there were themes around anxiety, there were themes around health literacy, so not really understanding the reason why you might need to come for this important appointment. So that was the first phase, and then the second phase was that we introduced an intervention where we employed our health coaches to contact people prior to an appointment to have that conversation with them around their planned attendance or non-attendance. And we were able then, when people were not sure about coming, to put in intervention. So we linked in with the voluntary sector and were able to support with transport. We did work around our communication so that we could improve our information that we were giving about why appointments were important, etc. And during the intervention phase, we saw that there was a change in attendance rates, and the gap between the least deprived and the most deprived got smaller. So that has informed a business case where we're looking at if we can introduce something more sustainably around that contact with people, and we're also looking at how we can predict attendances. So we know that there are some factors that are more common around attendance and non-attendance. So for example, if you haven't attended a previous appointment, you're less likely to come to your next one. And then what can we do, and how can we develop interventions to address that? And we've again reached out to local communities, so we've done a lot of focus group work with groups who maybe experience domestic abuse, people from different minority groups, to engage with them about how do we communicate better. So what would help you to understand why it's important to come, what language should we use, what messages should we include on our website, you know, is it so lots of engagement, and that co-design is very much embedded in the work that we do in the Health Inequalities Board. It's really about listening and responding and being flexible. And a lot of the work around colposcopies helped us to think about what are the kind of principles of the work we want to do around health inequalities. So we've come up with this quality improvement approach for health inequalities that starts with planning. And that's very much about what are we already doing, how do we understand it. Then we pilot things, we pilot interventions, we learn from that pilot and we evaluate it, and then what we find, we disseminate and we share, and we're trying to kind of broaden out our learning so that it kind of has that broad impact. So there's some examples. There's lots more because this space is very busy within the organisation. So new things that have come about this year are things like poverty proofing. So we're doing some poverty proofing within some of our pathways. We're doing work around dementia using the local health index. So it's a very kind of dynamic space where people recognise that the board's somewhere that they can bring work, they can have that kind of conversation, and it's a kind of vehicle for change. But in year two, our focus has very much been on developing the capacity and the capability around data. So we're looking at developing a population health laboratory approach, and Robert's an example of that. So we're looking at how we increase our capacity for a public health lens on data. We've got a joint post that's just started this week with the public health team here. So we've got a joint public health data analyst working across Northumbria and the council, and we're very hopeful that'll help us kind of have that system lens on the health inequalities data. And I mentioned about the embedding it into routine data, and Robert's going to give an example of how we're doing that. So again, that's a journey, but we're starting with particular areas within the trust. So we're looking at things like our cancer metrics, our referral times to treatment, and how do we understand that through that lens. So really, you know, I think we're on the right journey, and I feel very positive that we've got some really good examples coming through that are really they're being taken up by clinicians and colleagues in the trust. People actually want this, and they want to see this, and it feels really positive. So really good stuff. Embedding and integrating approaches to tackle health inequalities across the trust. So that's kind of, again, ongoing. We've got a workshop coming up around the clinical strategy, looking at how within our clinical strategy we can embed prevention, think about health inequalities. We've got lots of examples, so we're getting colleagues to share their examples. We've got examples around reaching out to people who are within the drug and alcohol treatment service, our respiratory colleagues. So all of this is kind of showing what's possible to then make what's possible routine and part of our everyday work. And then we want to complete our initial pilot projects by the end of this year, adopt that good practice, disseminate it widely. So this sharing of what we're doing is so important, this capturing of the evidence. So we've got links with the academic colleagues so that we can write up the work and communicate what we're doing, what hasn't worked well as well. Sometimes this is kind of difficult territory, so really important that we capture all of that. But yeah, and I guess linking all that with the core 20+5 as well. So we've done some mapping across the trust as to kind of where we're currently working within that space and what more we need to do to build on that. So I'll stop there because Robert's going to now talk about the data and bring to light some of that work that we're doing around embedding health inequalities into our routine work. Do you want to sit here, Robert?
Yeah, please.
Okay.
Just have a laser pointer. How do you move back using the clicker? Can you move back? It seems to have opened up on it.
The upper.
Ah, there we go. Thank you.
Done.
Cheers. So hello everyone. It was my intention to give a live demonstration of one of the prototype dashboards that we have here. I've just found out at the start that that's not going to be possible. So if you want to come and grab me at the end, I'll show you an example of what one of those dashboards look like. So I'm one of the public health data analysts, along with Chris Wilcoxon, who you may be familiar with. I think he's presented at one of these meetings before. And I'm Robert Taggart. We recently have taken on Claire Stebbins as well, but when I submitted these slides, she wasn't in the team, so apologies to Claire for not being on this slide. The aim of what we were trying to do is move the dashboards and reportings from the more static format in Excel that you may be familiar with to the more interactive format in Microsoft Power BI, paying attention to healthcare metrics through the public health lens of inequality factors such as deprivation, gender, ethnicity, age, that type of thing, such that they would be interactive, so they'd be updated in real time based on user input. They'd be intuitive, so there's no need to have an expertise in data analytics or indeed Power BI itself. Within 5 minutes of messing around with one of these dashboards, you're already an expert in everything that you need to know. And they would be informative, so they're subject to the same data quality standards as any sort of internal reporting that we do in the trust. So all the data and all the metrics are rigorous and accurate and produce valid insights. We currently have 5 of these dashboards in development. The closest to completion is the Cancer Oversight Metrics dashboard, which looks at cancer waiting time for treatments through the public health lens of inequality. We have 2 that are up for review. We have a self-harm one, looking at patient admissions for self-harm and how that relates to inequality metrics. We have the RTT one in development, which again looks at elective waiting times for procedures through the public health inequalities lens. We have A&E waiting times to see if there's any relationship between how people present in the A&E wait in relation to their deprivation and their age and gender and such. We also have one a little bit out of left field where we look at ONS statistics for fuel poverty on an LSOA basis and see how that relates to patients within that LSOA presenting to casualty with respiratory symptoms. So the one I'm going to talk about, the one that was intended to be a live demonstration today, was the oversights metric for the cancer weights. This data has 3 caveats. It only looks at patients with their first treatment for a new tumour or a metastatic tumour only, so any patients with recurrent cancers are not included in the data. The clock time for the wait starts at their initial appointment with their GP or the referral, all the way through the diagnosis journey until the very date that their first treatment starts. And we only look at patients whose appointment and treatment were within the trust only. So what I'll do is I'll give you a brief run through of the screenshot here. and that's not really shown on the screen. So on the top left-hand side, we have the count of cases by cancer site. On the top right-hand side, we have a breakdown in percentages through IMD quintile, and also the case counts in the middle. And on the right-hand side, we have the case counts by rurality, and on the bottom, we have the count of referrals of patients waiting above and below the 62-day threshold. Down the left-hand side, we have a kind of selection of buttons that will allow you to slice through the data based on the demographics that you're interested in. You'll notice at the bottom, or near the bottom, there's one for local authority, so you can split that between North Tyneside or Northumberland as you want. And you can also interact with the graphs themselves, so clicking on the chart on urology will update all the case counts based on how many patients have urology appointments. The second page of the dashboard looks at how long patients wait on average based on those statistics. So you see along the top, the average waits by the rurality. Down the right-hand side, you have the average waits by their IMD quintile. You have the percentage of them by their referral type. And you'll notice on the bottom that there's quite a bit of inequality in the average days waiting by cancer site. If this was interactive, you'd be able to slice through this and see that if you clicked on urology, for example, you would notice that the IMD quintile shifts such that the patients waiting in the lowest 20% will wait on average about 10 days longer than the patients in the most affluent areas. But if you come back to me at the end, I'll show you that working in live time. So based on that work, we have proposed some extra oversight metrics. I've spoken about the cancer weights, the elective care and the RTT and the self-harm admissions are actually built just now. They're just awaiting review for production. The ones that we haven't yet got round to developing yet is the access rates for mental health and the safe and high quality care, looking at infection rates for C. difficile and gram-negative bacteria. We've had a conversation with the team that are responsible for extracting that data, and they've provided us with some rudimentary data sets to begin building the data sets behind these. So thank you, and I guess I'll turn it over to you guys for any questions or suggestions.
Thank you very much, Bo.
No problem.
It was a very positive and uplifting talk. A range of interventions from cancer, lung cancer to tobacco dependency to. Thank you very much. Are there questions for Jill and yes, Derry?
Thank you. Just a quick question. Did I hear correctly when you were talking about the dashboard that it only covers patients who are with Northumbria's patients?
Yeah. So it'll, from the actual beginning of the journey, so if they have their initial appointment with Northumbria and their treatment with Northumbria, those are the only ones that are included. There are obviously a number of patients that come into the trust from other trusts, but we don't have full control over the entire cycle of the waiting time, so we discount them from our data.
That's useful clarification. I just wondered for this committee whether there's an impact for us in understanding the full picture then, because obviously a lot of people in Northumbria will be treated at Newcastle, won't they? So I think that's probably quite an important issue to think about in how this information is used and how we as a committee can use it going forward. So thank you.
Thank you. Yes, David, please.
Thank you, and it's very assuring to hear of all this wonderful work on public health and prevention. But the metrics are very, understandably, very objective, facts and figures and so on. Do you incorporate anything which is more subjective, such as the experience of patients themselves in your analysis?
Absolutely, yeah. So the slide I shared with you, which was our approach to quality improvement, we start with the data, and what the data does, I think, that quantitative understanding, is it helps us focus on where we need to do the deeper dives. So that kind of looking at other measures. So we do a lot of work in the trust around patient and staff experience. So there's a lot of feedback that we get from patients. So it might be that we use some of that feedback, but it might be that we need to then go out and speak to people. And this, what helps is if you don't have the data, if you don't start with that, you don't actually know where you need to focus your attention. And before we were looking at health inequalities in the data way, you wouldn't necessarily know. You'd have some kind of hypothesis or thoughts around it, but the data really helps us, I think, to be a bit more efficient and effective as to where we get that qualitative insight. And we do have teams within the trust that work with communities, and again our links with colleagues in you know, the council as well. So it might, you know, the work around colposcopy was very much around starting with the data, but the data doesn't tell you what you need to do about the inequality, it just tells you there is one. So that's where the kind of evidence base, looking at what works well, what other areas have done, but also talking to our population, talking to the people that we're responsible for, because often they have the answers that we would never think of. So it's really part of our model.
Okay, thank you.
Thank you. I'm trying to think how best to frame my question. We model deprivation by geographical patch to a degree. Yeah. Is there a risk that we miss much smaller pockets of deprivation within communities which aren't overall giving us that they're in an area? So in Northumberland we have some bigger rural areas, and I know you've got some rural factors in this, but how do we ensure that those people in very small pockets of deprivation don't get missed? That would be...
Yeah, I think that's a really good question. And I guess that comes back to the kind of expertise and the people that we as our stakeholders and that engagement. So, you know, again, the data just begins a story, and it's when you kind of hone down that you kind of have that, I guess, challenge around it. And there are often people that are living in areas where there isn't deprivation, but they have a deprivation experience. Often it can be felt much worse because the environment you're living in is very different for you than most other people, and services might not be there because they might be more in a very urban area, etc. So I think it's just something that we need to keep in mind and be very aware of. And that kind of, you know, cross-cutting board that we have, you know, you've got the voluntary sector, you've got local authority colleagues that are very much experts in the place, would be kind of helping us to kind of check in and check with so the board helps us to do that, I think. But yeah, it's very important that we're mindful of that. And health inequalities are quite nuanced. You know, how we measure them, you know, there are differences, you know, around sort of like minority ethnic groups, etc., who are living in deprivation but still have positive outcomes. So there's a lot to understand around it as well, and we always need to be very aware of all those things.
Thank you.
Thank you. Just building on Graham's point, and thanks, that's been a fantastic presentation building on from Alistair's. I think for me, what I'm reflecting on is how mature you are as an organisation, thinking about inequalities from the work, Alistair, you've done for years with Judith Stonebridge, and then you're taking that further and faster, Jill, with the wider team. And I think as a system, we're not all as mature in relation to our data sets as you are, which is to be celebrated how much you've done, and there's lots to learn from. But I think building on Graham's point, it's not an isolated work, is it? Because obviously you're looking at it from a patient lens perspective, but actually the board, we're looking at it from a resident's perspective and a place and a community perspective, and they're the same people, aren't they? So I think that post that we've got with Claire and that will and want to have much closer data set alignment, but then the qualitative voice and the voice of residents coming much more through, we can do that stronger together, can't we? And I know that's certainly the intention for us to do that. But I think, again, thinking about when you've said around what's in our control, that healthcare, public health inequalities is an absolute vanguard of innovation that you're taking forward. So it's been great to hear that, and continue to making sure we keep talking about residents in our communities, of which sometimes they're patients.
Absolutely, yeah. People don't live in hospitals, do they?
Yeah, I may add, you know, it's really impressive. It's very people-focused. And I was really, you know, interesting to see how you look at why patients do not turn up and what is the reason. I think the colposcopy appointment missing, and then doing some intervention. And then I think, in my view, internet also adds to the anxieties, because people have some symptoms, they go to the internet, it comes up with all kinds of information. People get thoroughly confused and put off. So it's nice to have that intervention approach at that level. Yeah, it's really good. Any other questions? Yeah, Neil, please.
Thank you, Chair. Yeah, I mean, a bit like Jill, I found that absolutely fascinating. Having come from the Trust, I was aware of the work that Public Health did with the staff group but I wasn't aware you'd moved so far with the interrogation of patient data, which is really, really interesting. It stimulated for me, Jill, to be honest. I think we need a link up in terms of trying to produce something similar between adult social care using your public health consultants. But the other angle, and apologies for putting pressure on other colleagues in here, but CNTW would be a really interesting one for us to get in and underneath this sort of analysis with, particularly around mental health issues and where they're actually linked to it. I mean, there's some common threads that we believe we understand about where mental health presents to greater degrees in other areas. But I love this idea of us, rather than being reactive, being much more proactive in terms of using the data to draw that out. And I think you're at the vanguard of this in the area, and I think this has been a fabulous stimulus for us to start to do that in one or two other bits and pieces. My brain's buzzing at the minute, I have to be honest. So, thank you. Yeah.
Any other questions? Thank you very much, Jill.
Thank you
and
for
Robert.
listening.
Thank
Thank
you.
you.
Cheers.
Thanks, Robert.
Right, we move on to item number 9, a verbal update from Liz Robinson and Kevin Higgins.
So hi everybody, it's nice to see you today and thanks for the opportunity of coming back to the board. We came in April, so not long ago, so it's really good that we've had this opportunity. There's 2 reasons why we've come back today. So it's to talk about the early research findings that are coming out of the Research Commission by the North of Tyne Combined Authority and the ICB. That we've been working together along with the 3 local authorities and to let you see these findings because they're going to go forward in part into the joint strategy that we're developing, and also to see the results of the survey that we sent out after the last meeting. Some of you might have seen and many of you have responded to, so thank you. So we'll start with Kevin if you'd like to talk about the research. Oh, and I'm doing the buttons as well. It's too much multitasking.
Thank you. As this says, this is a follow-up to the presentation in April. So just kind of a refresh, I think, of some of the issues we talked around there. We looked into some of the data at the last meeting, and that was really thinking about wider sort of work and health data, but we focused in on economic inactivity as a specific issue which is causing a problem to the labour market. So I think just a reminder of some of the data there. There has been some new data released, but I think the trends are pretty much the same as we talked about at the last meeting. So we have almost 47,000 working age people in Northumberland who are economically inactive. That's where they aren't in work but aren't sort of technically claiming an out of work benefit. So they're not in that labour pool. And again, the latest data show almost 11,000 of those are for it's due to long-term sickness, and around 8,000 of that pool say they want to work. So we're seeing those trends continued, really. There is also we're talking about economic inactivity, and unemployment is still relatively low in Northumberland. I think it's dipped since the last meeting. It's around 3.8%, but we are seeing the actual number of people starting to climb up every month. So we've got about 6,500 working age people in Northumberland who are classed as unemployed, who would add to that economically inactive pool. And we have over 19,000 households where nobody's working. So the impact of health inequalities, which talked about quite in depth in the last meeting, is also obviously having an impact on the labour market, because it's providing barriers to those people to getting into that pool of labour. And the data do still show that mental health, musculoskeletal and diabetes are the main 3 causes of economic inactivity. And as also was touched on, a lot of place kind of disparity with some of those issues as well, which we can dig into with the data. So just a reminder of some of the things that we're doing to respond to some of those issues. The main one that we're here to talk about today is the work with the ICB and North of Tyne Combined Authority and sort of constituent authorities on developing that work and health strategy. So we do have some of the sort of preliminary findings of that research, which Liz, you're going to go through later. We have the development of the inequalities plan, also establishment of Northumberland Employment Partnerships and Employment Network, and that's really looking at how we work across all organisations. We've got some kind of touch point and support people who are out of work and have health conditions, really with a view to sort of coordinating some of those services. I think we'll come on to some of the work with anchor institutions and how we're kind of sounding some of that out, but I think very sort of interesting to see the first presentation around the community promise and some of the content of that really sort of pertinent to what we can think about other anchor institutions kind of adopting some of those practices as well. And we'll have some of your sort of findings from the survey that relate to that as well. Joint strategic needs analysis on inclusive economy is complete. That one's live. We have an age and well analysis as well, which has quite a crossover with this work, which is in development. The Northumberland Major Employer Forum, which I think is meeting again next month. My colleague Sarah Macmillan will be taking some of the issues around work and health there to some of the major employers with a view to how they can think about their recruitment and how they support their employees as well in terms of kind of retention and return to work. And we also have a kind of refreshed a North East Work and Health network where we've got, particularly thinking of the interplay between local authorities, public health services and economic development services, and that's supported by OHID, and that's really looking at sharing, learning and good practice. So I think that demonstrates for me that it's quite high on the agenda across the region. So just on the work with the ICB and the North of Tyne Combined Authority, we do the plan is to have by the autumn an initial proposed work and health strategy that we'll sort of adopt across the North of Tyne initially, with the view to seeing potential for scaling that up. So I just wanted to highlight here some of the initial findings. We commissioned a consultant to do some research to inform the strategy. So I would just stress these things are things that will kind of feed into the strategy rather than sort of recommendations that will be in the strategy itself. And that was really done through looking at some of the data trends and kind of interviews with the organisations that will be involved in sort of adopting and implementing the strategy. So the sort of first finding, which is a fairly obvious one, we've got kind of northeast devolution coming up, as well as the ICB being relatively newly established, and so the first recommendation is about sort of exploiting the opportunities that will present to us. I think that's about making those strategic connections between the new North East Mayoral Combined Authority, the ICB and a lot of the other provider organisations that are involved in employment and skills support. And also Insights North East, there was an inaugural conference a couple of weeks ago, which some people may have attended, which I think was really sort of interesting in this field, and thinking about how some of that, you know, the research community can better inform policy decision making. Developing a shared programme of public service form to address inequalities. I think that's about pooling capacity and decision making, and again developing that more robust evidence base on what works. Also makes specific mention of the proposed prevention fund that would be in the potentially in the devolution deal, and I think quite understand it's unique that the devolution deal mentions kind of child poverty and makes the link to the impact that will have on young people coming through education and into the labour market. We've highlighted better integration of frontline support, which is happening on some levels, but I think that, you know, the research has shown that's something that could be stepped up and scaled up quite a lot. I think that's about sort of co-design and across health and economic development and other partner organisations, a more integrated work and health system. That's thinking about how some of those employment services work with health services, whether that's in mental health, physio and other health services. So developing more local models of intensive integrated support. So thinking about things like work hubs there, where you can, you know, potentially co-locate services. The IAPT services were mentioned before, and that's something that's been sort of trialled, having employment support integrated into there. So that probably fits under that finding. Creating and promoting opportunities for good work. See, the North of Tyne has its good work pledge, which I think is getting a fair bit of traction. I think about 120 employers signed up so far, which is a good start. And that's really about providing that good quality work, and with a view to anchor institutions leading on that as exemplars, and thinking about employment sort of route ways for people who fit into the category we've talked about before, who are out of work due to ill health. Better using community wealth building approaches to support development of local supply chains and improving employment conditions. Again, I think that's thinking about that sort of demand side, that work with employers to think about how they recruit, where they recruit. Are they recruiting from those potential pools of labour, which where we're seeing people are economically inactive and aren't going into those sort of pathways at the moment, and also how employers can think about how they kind of design those jobs, the degree of flexibility and support they can give to sort of help people with health conditions maintain those jobs. And I think lastly, just building on some of the principles of good work that we're seeing through the Better Health at Work scheme, as well as the Good Work Pledge.
Thanks, Kevin. So I think as we go into the next bit, you'll see a lot of crossover between what came out of the research, but what also came from your responses as a board, those of you who've completed that survey. So just as a reminder for any who weren't at the meeting in April, we posed these questions to board members around, you know, what would work well for this population group who are economically inactive with long-term health conditions. What good practice did we already have? What would a good system look like, and anything else you wanted to be fed into the work and health strategy being developed by the North of Tyne Combined Authority. So they were the questions. Without going into each question, I've kind of themed them sort of into two areas of what you thought would help people further to stay in work or get work if they're economically inactive for health reasons, and also where we could go further. So there was a lot of responses from yourselves around the role of employers, around flexible working practices, supportive sickness absence policies and making reasonable adjustments, and really understanding particularly those employers who have vacancies, high levels of vacancies, to understand the needs of people with health conditions, but also the benefits and the assets that they bring and the many transferable skills that they have. Also to think early on in somebody's treatment journey, if they have poor health and they're waiting for treatment, about their training and their work aspirations and those needs, rather than wait until someone's fully well to then think about getting into work, because really having a job is one of the best ways of improving health. So that's having those discussions early, and that doesn't happen without people being upskilled to do that. There was lots of examples of some really good services in Northumberland, particularly from the VCS, that help people build self-esteem, but these are quite isolated and potentially could work more alongside employability services as well. And also all these roles like health coaches, link workers, just thinking about while people are waiting and you're hoping they're waiting well and you're trying to improve their health, what can we do around their employability and their skills and their training at the same time, which is obviously another workforce development issue that we could look into. And so where we could go further, and there are examples of this already happening in Northumberland, where employability services, they actually don't just sit in an office and wait for people to come to them. They go to food banks, they go to cost of living events, they work with health trainers to look at people's health and employment together, and so there is a lot of really good things happening. I think there's a feeling from some that people are perhaps passed around a bit too much, rather than being held with a number of agencies working with them and addressing the underlying root causes rather than very episodic sort of symptom responses. Working much more place-based, but at a neighbourhood level, and integrating services together, and that could lead to perhaps us pooling funding and commissioning together employment and health services. And then feeds exactly back to the previous presentation about what's our wider role as anchor institutions. There's some really great examples, as we've seen today, of where some are even further, and what could the rest of us do around that. I know we've got a change programme, haven't we, around commissioning, which Jill is the exec director lead for. So we're hoping to get some of the examples you talked about today into that change programme. But what about the rest of the organisations here? So just finally to the next step. So we're going to the Major Employer Forum in July to talk about this very topic. We're going to continue developing that work and health strategy, and we'd like to come back to you when that's in more of a draft final shape, so you can comment on it. We'd also like to think about the social value commitments, like we've heard about today. Is there something we could develop that's more of a shared core set of social value commitments as anchor institutions? Is whether the board would like us to go away and start scoping that work out and working with partners on that topic. And then finally, the North of Tyne area seem to be advanced in some of these on this agenda, so we're really keen as the North East Mayoral Combined Authority develops that this work sort of scales up really onto that bigger footprint. So that would, Jill, so if there's any questions.
Yes, thank you very much. Thank you. Sorry. Yeah. Good research findings, and then ending up with some next steps. Are there any questions? Alistair.
Really good. I'm sorry, I missed a couple of minutes of it. I suppose my question is, and I'm seeing this clinically, that we're now getting third generations who've got no life experience of being economically active. And I think if your lived experience up to the age of 18 is that your parents and your grandparents were never economically active, your aspirations and understanding of the work environment and everything else is reinforced by that dynamic far more than anything else that we can do. And I wonder if there is something specific that we should start to do at the generational effect of economic activity. And that didn't really come, well, I couldn't lend it into the questions that were asked, and that might lend itself to qualitative research or some other bits, but it is definitely a pattern out there. And I have to say that if you're a child at school and you've got two generations above you that have never been economically active, the chances of you being unemployed because you've actually had a job to lose or anything else, they often end up with, you know, from environments where there are mental health and other issues within the families, and I suspect it becomes that is a default, which is a real challenge. And if you look at the figures, it's the economically unactive rather than the unemployed that are our biggest issue. And I think it would be great if we could do something to look at that in a targeted way, because I think there is a cultural aspect within that family culture that would be really powerful to be able to unpick.
Nicely put, yeah.
I think Kevin wanted to come back.
Thank you. Yeah, I think it's a really important point, and you know, whether any of the evidence says people don't have aspirations, or whether, you know, those jobs just don't look realistic to them. And I think some of the things, particularly with the major employer forum and some of the, you know, good developments what we're seeing in Blythe, I would agree it's making the link that people see those jobs as realistic options for them, which they may not do, you know, whether they're economically inactive or unemployed, and we would need to be a bit more active on doing that, and doing that early, and thinking about work experience and placement and a way to get people integrated onto those pathways. So I'm hoping that comes out in some of the findings.
Yeah, I think the Blythe's a good example where there's a lot of regeneration. There's the whole future of Blythe is based on offshore and energy, and the work that all those employees are doing in schools is not something I've sort of seen before. It's obviously not my field exactly, but there's a really good blueprint there. But yeah, it is challenging, and I can remember Cormac Russell saying something along the lines, most people get a job from their own networks, and if your family's not in a network where a lot of people work, then that becomes even more challenging. So yeah.
Thank you. It's a question and a comment. And Graham, I'm just thinking around the family hubs, and obviously the fact that it's 0 to 19, up to 25 for SEND. I'm just wondering from that adolescence part of the programming, if there are those links. And it's a curious question because I don't know the answer. If there are those links across to employability and the adolescent side of family hubs.
There certainly are links across with education skills being developed, but I think it's all part of the developments. And I think if we can have this as part of those consultations and developments, I think that'd be crucial. That's right.
And my comment was when we talk about the major employer forum, which is private sector, but we've talked a lot about us as large employers and as public sector anchor institutions and third sector anchor institutions. I believe there is a regional or northeast anchor institution network, but again, maybe that's something for us to consider at local level at the roundtable event in July. Well, what do we want to do as both private and public sector large organisations coming together potentially?
I think the anchor institution network is more of an NHS anchor institutions as far as I understand. So you're really quite developed in that, and I think it's just those principles could apply to other large employees in the private and public sector as well.
Rob, you want to say?
Yeah, thanks for that. So Rob Murphy and I handle planning and housing. We need to think as well about making sure we're absolutely all on the same page collectively here, and nudge the people in this room, because when you talk about a conventional view of regeneration or growth, the professionals involved in that are focused on getting inward investment, which you can measure on how many square metres of concrete they've got down or how many headline jobs they've created. And the single biggest lesson I learned was in the first generation of enterprise zones in this country, when all the statistics pointed to the fact that we put huge amounts of public money into getting inward investment to places, but only 8% of those jobs created in those disadvantaged places went to families that were economically inactive. The rest were just displacement jobs. In other words, yes, we tick the box of getting investment and jobs created here, but actually those jobs came in from other areas. So it sounds like a statement to the obvious, but being really clear that it's as important to secure what I call ground the benefits in terms of local employment, supply chain requirements that have been mentioned. That's as important as getting a developer to invest in an area. And that can be an uncomfortable conversation sometimes, because at the Devo level, that would argue for actually where will a development have the most benefit rather than where will it be the easiest to attract. Okay.
Thank you. Any other observations? No? Okay, thank you very much.
I was just going to
Sorry,
say,
yeah,
if you
please.
want us to circulate that survey once more, is that possible, Leslie, the one that went out at the end of the last meeting? Yeah, if we can, if anybody else, there's still time to respond to it, so thanks.
Thank you. That brings us to item number 5. Jill would give us a verbal update on the progress of health and well-being strategy that's being ironed out for a while.
Yeah, thanks, Chair, and appreciate it. It is taking a bit of a time to do, but just literally 5 minutes just to say that we do have an officers group that's come together to look at the strategy, which is now 5 years old, as you know, across the 4 themes. And what's been quite interesting as a collective, as we start to unpack the detail that sits within the strategy, it's pretty tricky to align directly measures against it to show what difference we're making, other than there's lots of great progress under those wide banner headings. So what we're progressing is a summary report that will show the work that has been done to date under these large headings, which has been quite significant in areas, but also that real appreciation of we're just completely in a different place to where we were 5 years ago. Yes, we've had COVID, we've got cost of living, but organisationally we're in very different places. And we've tried, as we've seen certainly over the last 4 or 5 meetings, to change the membership of this board to reflect the wider determinants of health more and all play our parts and within that health and wellbeing forum. So I just wanted to have a couple of minutes on the agenda to say we are on with doing that stock take. That current position report is still in line to come into October board. But actually we're very keen to now much more acutely and deliberately align the Joint Strategic Needs Assessment Steering Group with the strategy as well, because it's back to the points we've heard that data should inform what we're doing, evidence-based should inform, and then the qualitative work with our residents should inform. So I think some of the recommendations, just to be a bit of a spoiler alert, in October, is that whilst we had our development session last July and we said overarchingly the 4 themes were right, we might actually want to look at this a bit more strategically, but then have an action plan where we feel like we can measure progress against and have demonstrable change that we can track over time, that will lend itself to what we wanted from the inequalities plan was to be that culture and leadership shift, which I feel we're all talking much more around inequalities. I think, Graham, you said it at the last board meeting. Feels like we've got much more of a shared understanding of where we want to go. So let's make sure the joint health and wellbeing strategy is more akin to our aspirations. So.
Yeah, thank you very much. I think the ultimate goal is to have a strategy that is meaningful and strategic, of course, and relevant to what we are doing. And also we would like to put in some indicators, how we progress, kind of a milestones and everything. So as Jill pointed out, there have been lots of obstacles. You know, the recent one is being changes in the executive level. So we are getting there. Thank you very much, Jill. Thank you. Right, okay. So are there any questions to Jill on the progress of strategy before I move on? Thank you. That brings us to item number 10, forward plan. There are details at the end from pages 17 to 22. What are the items we would like to, we have scheduled to discuss? But I think I would like to make an earnest invitation here. If you have any topics, relevant topics to discuss, please come forward. I mean, it's not just a casual invitation. We really mean it. We would like to have some inclusive things. So please feel free to email me or Jill or Leslie straight away. And there is no meeting next month here, but there is one important one, which is Inequalities Roundtable. That's a New Begin by the Sea. So please make every effort to attend that one, and whatever it is, don't come here for the next meeting. It's not going to be here, because sometimes the habits can drive you automatically. At least it drive. I have come to this place by mistake several times. It is a New Begin by the Sea. Thank you very much.
Chair, before you finish.
Sure.
Thank you for reminding us about that event. That's
yes.
Fantastic. I have heard that there are 80, so it's going to be a really well-attended event. So let's all look forward to that. I'm also going to make an apology here that I was absent last week when we were talking about the planning of this meeting. Levi Buckley isn't here today, but I'm just going to, I don't mean to put you on the spot, Rachel, but if there was anything from an ICB perspective, given that we are not meeting next month, that you feel you wish to share today, and you can have a think about it for a second, but you don't have to. But I haven't had a chance. I just didn't want us to think that because Levi wasn't here, we couldn't give information on the ICB if you felt that there was something that you wished to pass on. But there may not be, it's fine. But I just wanted to, before we finish the meeting,
you're put on the hot seat, Rachel.
Thank you very much, Graham, for that. That was great. That's absolutely fine. I mean, I think obviously Levi is the new area director for the North, and I know that he will want to come and meet everybody, but obviously he does cover the North Cumbria, Newcastle, Gateshead, North Tyneside and Northumberland, but he will come and meet us all and say hello. I suppose the main thing to kind of talk about from an ICB perspective is that you'll be aware that ICBs have to make 30% running cost reductions by the end of 25-26. So the ICB, although is just coming up to a year old, it is going to go through another period of change and transformation. Now, in part, it would have had to have done that anyway, because actually it's been a very challenging year, having 8 CCGs become one organisation. I know that Sam herself came here to talk about that, but it's just really to let you know, I guess it's useful to know that that's what is the next sort of stage of development from a point of view of the ICB, and I'll be very happy to, we can obviously update you on that as we go, but it's useful for partners to know that, I think. So thanks for that.
Thank you, Rachel. Thanks. It's a good response, given that it was a last minute. Okay, so item number 11, urgent business. We do not have urgent business, but I have 2 important announcements to make. The first one is, last meeting we had things that are going wrong in the pharmacy sector, disappearing community pharmacies. So we discussed about it. So I was in discussion with Anne, Everton, Derry, and also with Jill. There are some issues which can be addressed at the ICB level, but there are some issues which had to be addressed at the higher level. So basically, I wrote a letter on behalf of you all to the Secretary of State for Health, basically asking him to rethink the funding model for the community pharmacies so that they can survive in the competitive area, and also more and more clinical pharmacists are going into, community pharmacies are going into clinical pharmacies. So we need to have more pharmacists trained. So these are the two items I emphasized in my letter, and the letter is going today. Okay, so that's announcement number 1. And final announcement is David Thompson of Health Watch Executive. He is retiring. This is his last meeting here, and he has been with us for 6 years. Thank you very much for all your service. Hope you have a good retirement life or whatever it is. Thank you very much, David. Okay, I have a card I wanted to give you on behalf of the board, but I suddenly realized I haven't written it yet, so I will write, I will write it, sign it, and give it to you at the end of the meeting. All the very best.
Can we give him a round?
Yeah. I think that brings us to the end of this meeting. Thank you very much. Oh, sorry, Neil, you have something to say.
Yes, thank you, Chair. Yes, could I just briefly mention the Better Care Fund? We had a conversation last week just
that
about
is,
the...
Oh, yes, I'm sorry. That is announcement 3. Yes, okay. We slipped my mind. Sorry, Neil.
Not a problem. I mean, people might remember Rachel and I had to bring the Better Care Fund last year to, I think it was the November or December meeting for retrospective approval because of the DHSC timelines falling slightly out of line between when you need to submit the plan versus our ability to seek governance approval through this board, who officially has to sign off the BCF. We have a similar problem this year, but at an earlier stage, and it is because the discharge grant that has been put in place for each local authority and ICB area to have a look at how it can support discharge heading forward into the winter months now has to form part of the BCF plan. We only got the format for reporting for that 3 weeks ago. So there was insufficient time to get the BCF plan adjusted to be able to bring it here for approval, and we have to submit that plan by the end of June. So in consultation with the Chair, and if it's okay with the board, what we plan to do, Rachel's team are still in discussion with the Acute Trust and with CNTW about components of that plan, but we expect to have it pulled together within the next 2 weeks. We will submit virtually the plan to all members of the board for them to get eyes on that and at least hopefully get a few days to offer any immediate comments on that before the deadline to submit to DHSC. We will then bring it retrospectively for proper approval and proper consideration to, I think it'll end up being the August meeting because the July one's cancelled. We'd have brought it to July, but it'll be August now. And there will be an opportunity there if we need to make any tweaks to it that we can do it at that point. So with everybody's permission, that's how we'd like to handle it. I do apologise. Again, it's just the compression of timescales by DHSC. I suspect a lot of other boards are having a similar problem depending on how they work their governance, but that's how we'd like to tackle it here, if that's okay.
With everybody, yeah. Thank you, Neil. Thank you very much. I should have, flagged it. I completely slipped out of my mind. Thank you very much. Now, officially, the meeting ends. Thank you very much for all of you to come. Thank you.